We start. All right. Well, good morning or good afternoon, everyone. My name is Beth Thielen. I am an infectious disease physician at University of Minnesota, and I am one of the co-PIs of our University of Minnesota NICER site. And I am very pleased that one of a medical student who did a did a rotation with me, Adeola Adeleke from Touro University, is going to be helping me co-present the course or the case today. And I'm also really excited to see lots of UMN and Children's Minnesota folks on because this patient has been cared for by a number of multi-specialist team across multiple institutions, and it's really excited to have them here to lend their knowledge of this patient and thoughts. Um, we are both okay with, or all of us presenting are okay with interruptions along the way. So if there are questions that come up, please feel free to unmute and ask your question or put it in the chat. And yeah, with that, we'll go ahead and get started. So let's see. So first thing I wanted to point out is we have two big pediatric institutions in Minnesota, and I know this is really confusing. And so myself, I'm at the University of Minnesota Masonic Children's Hospital, and about 3 miles away, we have the Children's Minnesota. And we are actually two separate institutions. We have two separate medical records that don't always talk to each other. But I think we are hoping through this case and others that we will build bridges of collaboration and utilize, maximize our shared expertise. And I think you'll see that through this challenging case. And with that, I will hand it over to Adeola to walk us through the HPI in this case presentation.
Good morning or afternoon. It's afternoon for me at least, everyone. Thank you for having me. So let's get started. So we have a 3-year-old fully vaccinated girl born in the US to Somali parents. So initially she presented with a lower back cyst. About 2 to 3 weeks, it started progressing into an abscess, which led her to present to her pediatrician. An IND was performed, cultures were collected, and then she was discharged on a 7-day course of Bactrim. She was compliant on her antibiotics, but there was no improvement. In fact, the lesion just got bigger in size. Mom said it became more tight, increasingly painful. They tried draining it more at home, but it stopped spontaneously. Over this course as well, the patient started developing fevers, vomiting, and severe insomnia secondary to the pain, which then led them to their next presentation. So, for her family and her social history, she lives with mom and dad. She has no siblings, no pets. She has been exposed to cats and kittens while in Ethiopia. Her last time being there was last winter. She was bitten and scratched there, but there are no known exposures to tuberculosis. She has traveled to Michigan and Ohio as well. Next, thank you. Her past medical history is quite dense. As you can see, there's a lot happening on this slide, but I'm just going to hit on a couple important things that are really important to know in terms of when we get to our differential. So she is a preemie. She was born at 29 weeks due to preterm labor. She had a initial screen that was positive for SCID. It was repeated, and at 30 days it was normal. She did also have a newborn rash, asterisk, big signs. She She was hospitalized in Ohio for lymphadenopathy, starting to question if there was some failure to thrive going on during this time. She went to Ethiopia, as mentioned before, some oral candidiasis. She continuously had infection. She had a sty, right inguinal cellulitis. She was admitted again for bacterial lymphadenitis. At this time, a lymph node biopsy was performed. She had some necrosis, some karyorrhexis, some fibrosis, and she had eosinophilic inflammation. She had negative cultures and she was also recommended to infectious disease at this time. She also had a visit to Children's, went to see an immunology NP as well. Then she had her most recent presentation, which is what we're presenting on today. She was hospitalized at the U of M for a back abscess, and she was treated with clindamycin, and her cultures came back and showed some MRSA. She had a CT done at the time, which showed some diffuse adenopathy and hepatosplenomegaly. Then she had a follow-up, which she did not show up to, unfortunately.
I guess I see Zach Shaheen on, and I don't know if Diana's on. At this point, from what I know, Zach, you never actually connected with this patient, but anything else you all have to add from this initial workup?
I I I don't know if Diana's here. She's our immunology team member who initially saw the patient, but she had I think a really great immunologic plan, but unfortunately some of the labs were unable to be drawn initially. And in that intermediary period where Diana's initial workup was ongoing is when they got hospitalized for that back abscess. And then by that point, I was a recent hire. I came over from the U to Children's around just a couple months prior, and Diana was already concerned about this lymphoproliferation. And since I'm a rheumatologist by training, had tried to hand them off to me, but they had thankfully consolidated their care at the U.
Right.
Um, so that's as far as Children's has been involved in this case.
Yeah.
Um, but we're excited to hear the updates.
Hi, Diana. Anything else that you have to add from meeting the family then?
Yeah, so I was concerned. I saw the kid in this on December 17th, and then I had a lot of immune labs. Dr. Bolani also was kind of involved, like as well, and we were talking about this patient. And then she didn't get the labs drawn on that day, so we had gotten some labs when she was in the ER, and so just really hard. I knew it was concerning, and that's why I did ask Zach about having his input, and then the no show. So I'm really glad that things got figured out.
Yeah.
Yeah.
And I would say we did get plugged into care over here, but I would say this pattern of having trouble connecting the family in appointments has been an ongoing struggle, I would say. So
Right.
Uh, this is Gwen. I'm a pathologist. I don't, I mean, I'm involved, I guess, in a way, but I haven't figured out the patient. But just from what you show here, when they did the lymph node biopsy, did they do a flow cytometry?
Not that I so this is one of the limitations of like I have the report of the lymph node biopsy, which I can show you on a coming they'll be on a coming slide, but I have not had we don't have direct access to the records to see what it's at Children's, so I might punt that over if anybody at Children's knows if that was part of the evaluation that was done.
Okay, because for
Yeah.
me, from pathology, I'm heme pass as well. So from pathology point of view, a lymph node biopsy and with a flow, you can easily see the double negative T lymphocytes, right? So that will be an easy diagnosis to point to the direction. I'm always conscious on the children because these are morphologically, it's very hard to diagnose.
Yeah.
So that's what I'm asking. And on the other note, because I don't see patient, I also want to kind of ask you guys, if you suspect that, maybe you should let the pathologist know, and then they will run the flow. Usually, for a small lymph node, people don't see leukemia, and children are real rarely, other than Hodgkin leukemia, they will have the B cell lymphoma and aplastic large cell lymphoma. But for the lymphoproliferative disorder, you don't really have a morphology you can go by. So flow is the only diagnosis that point to your molecular. So
Yeah.
just
I
Yeah.
will preview, and I'm not, this was done in our, I think this was done in our system, and she did have flow and had a normal double negative T population. So we do have that, and that was normal. I
Yeah.
don't know what was sent along with this sample.
okay.
There at Children's, they did not have flow. I just went to look through those
Okay.
records, and Beth, everything I had sent you is what they have in Children's.
Okay.
That hospitalization with the lymph node biopsy at that point, like infection was still one of the major drivers. So they did an extensive infectious workup at that time. Diana, I think you were the one that got consulted, and your first response was, we have to do at least a DHR to rule out chronic
Right.
granulomatous disease with follow-up immunology once this patient was improving.
Yeah.
Um, so we don't have those flow studies, which that would have been our next run of testing along with more formal like ALPS and other
Mhm.
lymphoproliferative
Right.
workup. Yeah.
Yeah. Yeah. All right. And I will move us back to catch Adeola up here. So, Adeola, take it away.
So thank you all for the input. I'm learning as I present as well. So these are some images of the newborn rash, I believe.
actually, this is the newborn rash up here in the
Okay.
upper right, and then these are just some pictures that were in our health system, kind of along the way of she's having these recurrent rashes coming up.
Got it. And yes, also had multiple non-specific febrile illnesses, multiple diarrheal illnesses. She also had ear infections, like 2 of them by the age of 2, but she didn't need any eustachian tubes, so I guess that was pretty neat to know. Next, please.
So just from, because I'm a pathologist,
Mhm.
I'm curious, when you have a multi-infection, don't you work immunodeficiency right away?
Yes, I mean, I think that was the intention, and I think and concurrently with some of this, she was getting referred to immunology, and I think we were having hard time getting her consistently plugged into care.
Okay, all right. So that's why my husband said that you don't know about patient, you don't know about the background. It's like, sorry.
So here are some charts. We have a growth chart and a weight chart. And you can see that she's just really consistently in the lower quartile. There aren't many fluctuations in her weight. In fact, there are none at all. She's just conglomerated around that lower percentile. And same thing with her height. She's not doing well at all. She's consistently conglomerated around the lower percentile as well, which is what raised the concerns for that failure to thrive as well. So for a physical exam, this is the most recent one. Her physical exam was pretty benign except for a couple things. For her skin, she did have that IND site covered with the dressing, but there was no significant rash at that time, so that was good. Her lymph nodes, though, she had a bunch of lymphadenopathy. She had multiple enlarged bilateral cervical lymphadenopathy, submandibular and post-auricular lymph nodes that were enlarged. She had a single palpable right-sided supraclavicular lymph node and bilateral multiple inguinal lymph nodes at this time. However, they were non-tender and there was no flatulence and they were mobile. That's always a good sign. At this time as well of that, of that physical exam, you could see there was no hepatosplenomegaly. That was seen later on CT. So moving on.
Can I chime in since you're a medical student? Sorry. So for non-tender, it's not really a good sign, right? For tender, it's a good sign. It's mostly infectious.
Oh.
I think we're coming from a bias. Adeola is working with me as an infectious disease doctor. So
That's okay. I'm just saying because because for our future care, we depends on you.
yeah.
So
Yeah, we have bucketed this as we do not think this is necessarily infectious.
yeah, no, I'm sorry if I take it over, but it's just like, okay, this is educational. I like it. And multi-lymph node and mobile for lymphoma, you don't have a fixed lymph node non-mobile, right? If you have a subcutaneous mass or something non-mobile, that's not a good thing. For lymph node, if they are not getting out of the capsule, they are mobile, right? They're not like a tether to anything, they're movable.
Yes.
Okay, all right. This is just for medical school education.
Yes, we already talked about the biopsy, but the most important thing I should take from that biopsy was that there was no evidence of infectious causes and there were no granulomas. So,
Yeah, and I will say I will add in, look, I reviewed some of the testing that was done, and they, not only did standard cultures, but they also had gone and done 16 SPCRs to look for sort of fastidious organisms or things. They did a M tuberculosis PCR, and so pretty comprehensive ID workup, and it came up kind of with nothing much in terms of an infectious etiology.
yes. For her labs, the labs that were out of range are the ones that are highlighted in red. She had a pretty elevated procalcitonin, her sedimentation rate was high. Her hemoglobin was also pretty low, so it looks like maybe there's some sort of anemia going on. All her other things were on the lower side too. Her hematocrit was normal, but it seemed like it was on the lower range of normal, just hitting the normal barely. Her monocytes were also low, her lymphocytes were low, but her neutrophils were super high. And so that was concerning. I guess from a medical student standpoint, it would make sense if she's continuously getting these skin infections, especially since neutrophils are the first ones to the rescue in terms of immunologic response. But yes, she also had, as you can see at the bottom, elevated eosinophil levels, which I find to be personally very interesting, considering we only learn, oh, if there's a parasite, then you're going to have eosinophilia, which none of that was seen. So that's also pretty interesting.
Okay. So he has thalassemia, probably. You have an MCV of 61. Your hemoglobin is mildly decreased. You probably so your RBC is normal, and that's usually kind of like a thalassemia sign. Hey, combination of iron deficiency, you don't know or not. But those are minor things, not related. Just sorry, I can't help myself.
I appreciate it.
And the eosinophilia on that level, what's the percentage?
Are you asking about the percentage, sorry, at the
I mean, you have a neutrophil percentage, and then you have
oh,
eosinophil. You put the absolute, right?
right. Yeah, I think these were sort of a snapshot.
Yeah, no, that's
the
okay. I'm sorry. I apologize. That's fine. Yeah,
Yeah,
that was
down below are the absolute counts, and I think what I've this is I subsetted a selection where we had the most her peak eosinophilia, which was back in 2023, where she had a absolute count of 5,000, 5,000 for EOs, and has sort of fluctuated at times being elevated, and more recently has had more normal eosinophil counts. But I think where we're sort of leading the group of thinking about is Job like a Job syndrome, a hyper IgE sort of syndrome with this recurrent skin infections, and eosinophilia was sort of where we were, thinking initially of common, commoner immunodeficiencies, something worried about something in that kind of spectrum.
okay.
All right, we have some more labs.
And I will also say a little bit of this is a mashup of kind of putting things together. And so not all of these were checked at the same contemporaneous with like her hospitalization in January, where she was presenting with this back abscess. We're kind of filling in some data across time just for the interest of kind of putting things together. But not all of this was kind of emerging at necessarily at the same time.
For these labs, I'm actually going to call on Dr. Thielen because I don't know the normals currently for the immunoglobulin levels, nor do I know them for the CD counts.
Yep. So I think I guess sort of some high level comments. So at the time when she was presenting with acute infections like this, a back abscess that was culture positive for MRSA, she did have inflammatory markers, and I think those seemed to go down at times when she was more clinically well. The labs that we had, so because of some of the challenges with her getting her into follow-up, we had sort of sparse lymphocyte subsets. So when we actually, our team, I had actually seen her when she was born for the positive newborn screen, and so that's these in the lymphocyte subsets. You can see those are from day of life 9, where they were markedly low across all cell lines, and then I'm there was some sort of loss of follow-up where her subsequent newborn screens were positive, and so I think she sort of didn't get kind of followed in care at that point. And then the next set that we have for her were from September of 2025, so about 4 months before her presentation of the back abscess, and things looked generally pretty good. As we mentioned, the infectious disease team at Children's had checked a DHR on her when she had presented with the lymphadenopathy, and it was normal. And then at some point along the way, I can't remember exactly where this is, we had filled in flow, and she had normal double negative T cell populations. And then as Zach mentioned, we had some troubles getting her in. Diana had recommended checking some total immunoglobulins and checking some titers. And there was a little bit of, because of these difficulty getting her into care, some of those filtered in gradually. And so she had initially had pretty robust, I mean, IgG levels, and actually, I think it was an elevated IgM, and then has more recently has seen some dropping in her IgG levels. And then concurrent with that, we were able to get, I think this was maybe even just recently in April, pneumococcal titers that looked pretty terrible for her, given that she had been vaccinated, including with one dose of PCV20. And she had non-protective diphtheria antibody titers and protective tetanus titers. So just to kind of round out the immunological workup that we had pulled in, kind of smattering both before and after this presentation with the back abscess. And then I am an infectious disease doctor, so I have to tell you all of the comprehensive ID workup that she had, which included HIV testing that was negative. She was EBV IgG positive, but PCR negative, CMV completely seronegative, and she had negative Brucella, Bartonella serologies. She had initially an intermediate quantiferon that subsequently was negative ×2. She had strongyloides serologies and Toxocara serologies and Lyme. And so looking at this list, I think strongyloides with a history of travel certainly can be associated with intermittent eosinophilia. So I think this was potentially more, checked in the setting of some international travel and the eosinophilia. Toxocara, particularly in young children, can cause hepatosplenomegaly and eosinophilia. So I think these are sort of first line ID tests for particularly for young children. The Toxocara is something we think about with like potentially hepatosplenomegaly and eosinophilia. And then the Lyme, she lives in Minnesota, where we are a Lyme endemic region. All right. Adeola, do you want to take over?
Sure. I'll hop back in. So imaging results, she had 2 CTs and an ultrasound. So she first started off with that CT that we discussed earlier. The big things to note, she was negative for fungal and acid-fast organisms, but there was eosinophilic inflammation. There's also no evidence of malignancy, which is always good. In January of this year, she had an ultrasound of the head and neck soft tissue. Overall interval increase in the bulk of her cervical adenopathy on the left. Once again, no evidence of abscess formation, which is good. And then she got a CT of her lymph nodes, her liver, and her spleen. I believe she got a full body CT, but these are the ones that were important to note. So her lymph nodes, she had bilateral axillary adenopathy measuring up to 12 millimeters, and she had multiple prominent supraclavicular lymph nodes, and she had mediastinal and hilar adenopathy. And then for her liver and her spleen, just some enlargement with hepatomegaly, 10 centimeters, and splenomegaly, which was about 12 centimeters. So, what is your differential at this point? If anyone wants to chime in, this was probably my favorite part.
Yeah, what is the group thinking at this point?
You can chat, speak. I don't bite.
Look like as a pathologist, I want to see the lymph node biopsy.
Sorry, did you say you wanted a lymph node biopsy?
Yeah.
Are you, I guess, what are you thinking relative? Because we have this biopsy from a little bit ago of the cervical node biopsy. What would be you want a new biopsy at this point? Or and where would you, what sorts of things additional things would you like to do?
How much changing is the diffuse lymphadenopathy was there all the time? Or is that because all this rashes all over and then now she get it?
I would say it seemed like the lymphadenopathy has been present for a more prolonged period of time of well over a year at this point, had been biopsied early on in one of these cervical nodes, and it seems like overall it's becoming more pronounced over time, and we're now seeing hepatosplenomegaly on the CT clearly indicated as well. So I would say it's been slowly progressive over a 1+ year, period of time.
And hepatosplenomegaly, was the liver functions all normal?
Yes.
Okay. So I think for me as a pathologist, of course, I don't see patient. I don't know everything like occurred with what's changing. But to me, I think if the previous lymph node biopsy is very convincing, I guess maybe not. But since you didn't have, I don't know, I couldn't remember your flow was ever done or not done, and no increase CD4, CD8 double negative population is real or not. I probably want to see the biggest lymph node biopsy. That's one. And two, we are already thinking is autoimmune. I think the inborn immune error panel should be run. So that's all I can think because I am limited from the laboratory point of view.
Okay. All right, and there's a few comments in the chat, and if people want to read, go ahead. Otherwise, I'll just read out. So some type of inborn error of immunity causing recurrent infections, a lymphoproliferative disease. She needs testing with an NGS panel for an IEI ALPS-like disorder. And then agreed, but CT scan is not the appropriate modality to call hepatosplenomegaly. That is a clinical exam finding. I will agree, and I'm not entirely sure of the thoroughness perhaps of the commenting on that in the notes that we have at this point in time. And then
has a thalassemia, so that can cause I think he has probably have a thalassemia minor, but not really major, because based on the CBC. So that can cause hemolytic, can cause hepatosplenomegaly, but I don't know to what extent it's going, right?
Yeah. And I don't know, is anybody from from hematology, or I don't know if anyone here who's or Alex, or if anybody's on from heme to comment on the thalassemia. I saw that mentioned in the notes, but I don't know that or as a consideration, but I'm not sure I saw any full thoughts on that.
It's probably not a major, because if he hasn't had a transfusion, I'm still on my side, but your side, if you have a hematologist, you're welcome to comment. From my looking at the number, you have a RBC 5.6 or something, your MCV 61, mild, you have a hypochromesia. So he probably have a combo of thalassemia minor plus iron deficiency. Just by looking at that number has to be confirmed. But it shouldn't cause that big a change of a hepatosplenomegaly, so I don't know how much.
Yeah, and so there's some comments agree it could be alpha thal trait plus IDA, and then should not cause lymphadenopathy even if it's thalassemia intermedia. And then the minor will not explain the splenomegaly, and agree. So people are commenting that they feel like there could be multiple things going on, and that thalassemia alone wouldn't explain the splenomegaly.
Yeah. Thalassemia minor would definitely not cause hepatosplenomegaly. Like I said, if it's even thalassemia intermediate, I'm sorry, I missed the hemoglobin.
Iron deficiency anemia, thanks.
Yeah.
Thank you for interpreting for us ID folks. Let's see, here's our CBC.
And Dulek here from Vanderbilt. I figured I'd toss out a question for the hematologist. It seems like a weird combination of sort of cutaneous bacterial infections and lymphoproliferation, and labs that would suggest more of a sinopulmonary predisposition. And that's not lining up for me. And is it surprising with this degree of lymphoproliferation that there aren't really, I apologize if I missed some significant cytopenias that have developed?
Was there a hemoglobin electrophoresis sent to differentiate alpha from beta thalassemia trait?
I don't remember ever seeing one in her records. I can't say 100% since we have data coming in from multiple sources, but I do not remember ever seeing that being sent.
Right. A hemoglobin of 10.8 with an MCV of 61 looks like thal minor. So it's either a beta thal minor or a 2-gene deleted alpha thal minor, and that would not cause hepatosplenomegaly and certainly not lymphadenopathy.
Yeah, I think he has multiple things.
All right. Well, I will moving along. I think Adeola had a few sort of had some frameworks to think about, a differential, agreeing that we feel it's a little bit of a puzzling story, and how can we think about differentials for different elements and kind of hopefully find some kind of common maybe some kind of unifying diagnosis. So, Adeola, do you want to take it away?
Yes. So this part was actually really fun for me, just figuring out, oh, if we're going down a differential route, what causes this? There's hepatosplenomegaly or there's lymphadenopathy and there are recurrent bacterial infections. What in the world could this be? So I divided it up into three different sections. So we have infectious causes, we have hemonc causes, and immunologic causes. And so this first table just demonstrates a bunch of infectious causes that would cause hepatosplenomegaly. You have EBV, CMV, TB, brucellosis, Pasteurella, HIV, I believe that's histo, and MAC. And so looking at these, you can see that there are some overlaps in terms of, oh, this disease causes this, our patient had this, but then she didn't present with this. And so just going down the line of differentials like EBV causes that lymphadenopathy, and it causes hepatosplenomegaly. It's there, the rashes, but with her testing, she was seroneg. Same thing with CMV, she was negative for tuberculosis. Brucellosis was there. There's some hepatosplenomegaly, and but her risk factors don't really line up with that. Same thing a little bit with Pasteurella, HIV negative, histo. She had no fungal etiologies when she had her lymph node biopsies done as well. And so, yeah, it was just pretty cool going through the differential, seeing things that she could have but didn't.
And just a couple things. So, brucellosis was sort of something that we think of when traveling to the Horn of Africa, because that's an area where we commonly see brucella, and so potentially that was sort of the epidemiological link that kind of from an ID standpoint made us think about that. And I will jump in and say, we also don't really have a reason. Disseminated MAC is not normally a disease of a normal host, but assuming if we're invoking some kind of immunodeficiency, I think something we would think about is causing adenopathy and hepatosplenomegaly in somebody has some T cell mediated immunity dysfunction. And I will jump in and say our excellent ID sleuth, Rachel Strandmark, jumped in and said hemoglobin. She had a normal hemoglobin electrophoresis at about 9 months of age. And then Dan Dulek is commenting, you could put leishmania on there. Yes, 100%. I agree with leishmania as well.
Leishmania you can see by biopsy, and they didn't report it, right?
I don't know.
I mean, you said
It's
with
in the liver. I don't know that I would. I actually don't know if I would see it. I don't know about a lymph node.
you can, if you biopsy, if you have it in there, you can see it.
Yeah.
But if you
Yeah. All right. Moving on.
Yes. And then you have, I just threw this table together because there are a bunch of things regarding the blood that can cause hepatosplenomegaly, especially because those are really big centers for our red blood cells. So we had myeloproliferative neoplasms like polycythemia vera. I'm forgetting what ET was. There's so many acronyms, but hepatosplenomegaly is very common in these disorders, but according to her blood readings, I'm pretty sure, thank you, essential thrombocythemia. Essential
Thanks, Mira.
thrombocythemia. Thank you.
Mira's one of our transplanters.
Oh yeah, I would explain it. But
Yeah.
she didn't present with any of, I guess, those.
Yeah.
I'm skimping on the word that I'm looking for, but
I think this
safety.
may be duplicated, but
It was on, there are two different things. I
oh,
saw
got it. It's a different
all of the
list.
same slide. You had lymphadenopathy, and then
Okay.
you had hepatosplenomegaly for the first one. But yes, she didn't have any of those. Just a part of the differential for things that are really big in causing hepatosplenomegaly. And then the last category we looked at were the immunologic causes of hepatosplenomegaly and or staphylococcal infections. ALPS, there are lots of people that put in the chat. So ALPS is one of them. The childhood was there, lymphadenopathy was there, splenomegaly was there. But the immunodeficiency, the fevers, I mean, she came and went.
Mhm.
Kikuchi and Castleman disease were things that were all from the brain of Dr. Thielen, not any from mine. That is not something not something we learned about. So I'll let her talk about those. But the hyper IgE syndrome was really big in terms of the neonatal rash and the recurrent staph infections. That stuff is huge. And she also presented with mucocutaneous candidiasis. She had thrush going on one occasion, and then she had oral candidiasis on a second occasion. So that was really big in terms of looking at, oh, maybe she could have Job syndrome. Odalin also came from the mind of Dr. Thielen, so I will let her let her talk about those.
I don't have a whole lot more to say other than a little bit was this was formulated after we knew what the diagnosis was. So maybe in the interest of leaving space for other things, we'll skip to the the reveal. So I think genetics to the rescue here, and I hope if maybe Dr. Billington, Charlie Billington might be on to kind of weigh in, but basically at very early in life, she had been seen by genetics, and at that point they had just done a limited G banding and a microarray, and there was nothing really revealing, although there were fairly substantial regions of homozygosity that were identified. The next time she encountered a genetics team, they actually was with this staph back abscess, and they actually at that point recommended whole exome sequencing, which was done, and it revealed homozygous variants in the gene caspase 8, and it was specifically a missense variant, this arginine 233 to tryptophan variant at position 2, and it had been described in heterozygotes in nomad, but had not been described in the homozygous state. And I don't know if Charlie is anybody from our Charlie, are you on the call? Like he might not have made it on. He was out of town at a meeting. So in any case, in talking with the lab, they felt that this was probably based on sort of some reviewing of the mutation, the changes, that it was probably pathogenic. And I think like it was likely an explanation for this patient's syndrome, given the clinical overlap with the syndrome that this patient was presenting with. And I will if we get Charlie on, we'll try to have a more wise genetics perspective on this. But if not, I will walk through kind of some of the background. So these are just the criteria for making calls about variants. And I will give you my ID doctor perspective, which is I think that there's these population databases. We don't see this in the homozygous form in nomad. It's expected based on the described disease expected to be autosomal recessive, and when variants in this gene have been described associated with disease, there are established functional assays, which I will show you some of the data from the papers looking at functional assays, but we don't yet have functional data on this variant. We know Ma in this case we had a duo exome. Oops, let's see. Yes. Did you want to make a teaching point about, there's a comment in the chat, the exome would have detected beta thal minor or intermediate, but cannot usually report on alpha thal.
Yeah, so the basically so I'm a genetic counselor at Nemours in Delaware, and the alpha globin genes, while they will be covered by exome is not very good at detecting deletions and duplications of that size. So I have never seen an exome report an alpha thalassemia minor like this. Additionally, exomes don't tend to report on carrier status of these kinds of things. So generally, if you're concerned for alpha thalassemia, you should do the common alpha globin deletions and then go to sequencing if needed. Although with the exome, you would have ruled that out. But if there's still concern for alpha thal minor, then there would need to be separate testing for the alpha globin genes.
Okay, thank you. And I guess another sort of a follow-up question is coming back to the secondary findings. And I think in this case, we had microcytic anemia listed as a clinical indication. So it seems like, I guess, again, this is my doctor perspective that would have been sort of an explanatory finding for some of the indications. But do you have any comments on like when it would get batched to secondary findings and maybe not reported?
So alpha globin, I don't think is on the secondary findings list. Let me double check that, but I don't think it is. So it would have only been likely reported if she had like all four deleted, which she would not be alive probably if she had that. So I don't think that that would be something that would be reported on exome pretty much ever, unless it was maybe three deleted or four deleted.
Okay, thank you.
Sorry, I think I misguide people to thalassemia. I didn't mean that way. I just meant he might have a combination of that. When you have a minor, there is no treatment other than transfusion dependent. So there is no really need to go further for that. It will not cause other problem.
Although you would maybe want to avoid iron supplementation. So you would need to make sure that it was true iron deficiency anemia before treating with iron, because iron supplementation would not help a child with alpha thal minor.
Yes.
All right. So in any case, this is my ID doctor again, genetics sort of first, when I sort of see this coming up, I look in OMIM and look at how this gene has been described. So this was the entry for caspase-8. I would say most of the examples of where this is being associated with disease is in the cancer space. So you can see your breast cancer, hepatocellular carcinoma, lung cancer, and then there's this really small immune disorder area. And so that's this caspase-8 lymphadenopathy syndrome, which is, as I said, expected to be inherited in autosomal recessive fashion. If we look at the original description of this disease, was described in a 2002 Nature paper with a series of cases, pleiotropic defects in lymphocyte activation caused by caspase-8 mutations lead to a human immunodeficiency. And you can see the two patients are in the first and second column here, and then there's some unaffected siblings. And I think one of the things that you can notice, which we didn't see in this patient, is this inverted CD4 to CD8 ratio. She actually had a pretty high CD4 to CD8 ratio. You can see in terms of the clinical symptoms, I think you'll see a lot of overlap with things that our patient is having. So failure to thrive / short stature, lymphadenopathy, splenomegaly, eczema, she had maybe one episode of pneumonia. She had at this point not had HSV labialis. And then some chronic issues with chronic diarrhea in response to and poor responses to pneumococcal immunizations. And so I think as we're looking at this case, quite a bit of overlap in terms of the phenotype with what was published in these first cases. This is the molecular method slide. So they did these are a couple of select experiments looking at some of the assays that can assess the molecular function of this defect. So the panel C in the upper left is a caspase substrate cleavage. And so you can see if the wild type protein is expressed, you get sort of a linear increase in cleavage of caspase substrates over time. And you don't see any cleavage in the patient's mutant samples. If you look at how well it mediates cell death. So in panel D, these are Jurkat cells which naturally don't have a caspase-8 function. And so they've either overexpressed a wild type version of caspase-8 or one of the patient mutant samples, and then treated the cells with fast antibody to trigger apoptosis. There is not you see death in Jurkat cells with the wild type, but not the mutant variant. In terms of the panel E in the middle is looking at actual caspase cleavage. So the caspase-8 enzyme is cleaved as part of the activation pathway, and you can see small fragments indicated by the little circles in the normal wild type caspase-8, whereas in the patients you don't see that cleavage product. You see there's impairment in IL-2 production in patients with this caspase-8 deficiency when the T cells are activated through the T cell receptor, and you see impairment in NK cell stimulation. And so I think understanding where these molecular defects are, I think can be tied back to what we end up seeing as manifestations of this syndrome in patients. And so here's a more recent case series looking at some of the other features in a different patient set. And I think notably, you see some of these same lymphadenopathy and splenomegaly. Also noted in the literature, some of these cases seem to have some neurological symptoms, so Bell's palsy, and I'll show you a more extreme example in the next slide. There's also some systemic autoantibody production, and so things like immune cytopenias and some inflammatory bowel disease are also described. In terms of the protein structure, these are sort of the prototypical domains of this group of proteins. And so there's these dead box areas in caspase 8. There's two of them, and then there's the active caspase domains. And if you look at these, the way that this protein works, there's a pro-domain on the N-terminal portion, and then the enzymatically active portion is on the C-terminus. And the described pathogenic variant sits right here at kind of the very proximal to the cleavage domain that's when separating the enzymatically active caspase domain from the pro-domain of the protein. And our patient's variant sits right at this juncture of just on the pro-domain side of this cleavage site. And this is a little bit of an old paper showing some other features. So this gene is known to be has multiple splice variants. And there's a variety of splice variants that can lead to loss of function that's described in the literature. Skip through that in the interest of time. The function of caspase 8 is interesting because it has both apoptotic and non-apoptotic functions. And so this figure illustrates really the apoptotic function, which is downstream signaling through Fas ligand. And so we see, I think, probably some of the reasons for overlap with the ALPS. Why this is an ALPS-like disorder is it's really kind of in the same molecular pathway, just a bit downstream. And then the other important, I think, pathway that this is involved in is in this RIPK1, RIPK3 signaling pathway. And I will not go over this in detail, but just by way of saying, I think this is a quote from one of these papers. So caspase 8, in response to stimulate tissue damage and infection, cleaves the cytoplasmic receptor interacting protein kinase 1 and 3, preventing the formation of a complex that would otherwise trigger necroptosis, a highly inflammatory form of cell death. In ALPS-CED, which is the caspase 8 associated syndrome, this non-apoptotic function of caspase 8 is deficient, and the inflammation seen in atopic dermatitis and very early onset inflammatory bowel disease is not primarily a caused by a lack of apoptosis, but rather a dysregulation of cytoplasmic RIPK1, RIPK3 signaling, which proceeds unchecked, leading to necroptosis. And so I think hopefully thinking about these two pathways in which caspase 8 is associated can sort of lend some explanation to why we see some of the features overlapping with Fas ligand variants and ALPS, and yet also some potentially slightly different features. So I mentioned that there's a polyneuropathy as described with this. So this is another case report of this disorder in caspase 8, presenting with a pretty severe, widespread polyneuropathy and evidence of hyperactivation of the mTOR pathway, which will come up a little bit at the end as we think about management. So this is really this syndrome, what's described in the literature, combines components of autoimmunity, so immune cytopenias, antithyroid antibodies, pulmonary fibrosis, neuropathies, or sorry, not pulmonary fibrosis, but rather for FAS, neuropathies and very early onset inflammatory bowel disease. And then there's also manifestations of immune deficiency in terms of poor vaccine responses to vaccines, sinopulmonary infections, and severe HSV. And as sort of a prelude to this actually happened after we got the genetic diagnosis. We had an episode of both PCR-confirmed HSV-1 stomatitis and oral candidiasis. The child presented to the emergency department with a unilateral facial droop with a normal MRI and was treated for Bell's palsy. And then at that point, we were finally, after able to get the patient in to see Ryan Nelson, who's our allergy immunologist. He made some recommendations for Bactrim prophylaxis, for fluconazole prophylaxis, for immunoglobulin replacement, and some getting this patient into hem-onc and some other possible downstream therapies. And unfortunately, in keeping with a pattern that we've seen kind of frequently in this child's course, they missed their 1 month follow-up with Dr. Nelson. So we're a little bit having a bit of a hard time consistently engaging this child in care. And then there's also an intention in a future visit to send this assay for apoptosis assay. I just wanted in the last, closing minutes, just wanted to kind of give some plugs for thinking about for, the equity and inclusion aspect of this story. So I think this is a review from a little while ago now, but reminding us of the point that that inborn errors of immunity occur globally, and probably places like where this child came from in East Africa is probably a place where there's the most underdiagnosis of primary immune deficiencies. We know from SCID that there's population-specific founder variants that cause disease, and I think thinking about how this might apply to other disorders, there are likely potentially locally specific just variants that exist for different types of disease. And I think it's important to remember that there's underrepresentation of non-European populations in these databases. And this has important implications for diagnosis, which sort of the inverse of what this patient had, which is where we also have a harder time classifying variants of uncertain significance that may not be clinically meaningful because we just haven't represented the normal variation in a globally diverse population. I think a takeaway that I have from SCID screening is that for a long time we had big disparities in mortality from SCID. And I think with some of the findings from PIDTC that we see that gap in disparities closing as we implement universal newborn screening for SCID. And I think that for me, that's an important lesson of how ready access to screening may help close the gap in some of the disparities that exist in other inborn errors of immunity. And in Minnesota here, we're making some strides in this direction. And so we recently had legislation that required insurers to pay for rapid genome sequencing in critically ill children. And I think this has made it easier to get inpatient genetic testing for some of our kids that we think have severe illness related potentially to an inborn error of immunity. And Minnesota is also going to be a site for the upcoming Beacon's genomic newborn screening pilot that was discussed extensively at CIS last week. And so I think, I think there's some great opportunities for some positives, but I think we're also this case illustrates a lot of the barriers for care we experience here, which include being split between healthcare systems and sharing information reliably across those systems. The need for interpreters and the importance, I think, of having in-person interpreters and high quality medical interpreters to talk about these complex, nuanced issues. I think there's a general need for health literacy around genetic testing and immunomodulation and the important differences between the place for prophylaxis versus treatment of infections. And then just to close, I want to raise attention to the enhanced immigration enforcement that happened in Minneapolis this spring and almost certainly negatively impacted this patient's care. So people may have heard, we had Operation Metro Surge, which is an enhanced ICE operations that happen in the metro area in the Twin Cities and also extending into greater Minnesota. And this is I'll end in a quote from a commentary that a number of us doctors in Minnesota signed on to, sort of really trying to raise awareness of the impacts that enforcement had on our patients. And so, these patients are terrified when we call to check on them. They're scared to leave their homes, scared to drive, scared to take the bus, scared to walk across a parking lot to a clinic. And I think this is really something just to keep in mind of, our care doesn't stop at the bounds of the clinics. We really need to kind of respond to the whole climate and the place where we provide care. And I think this has been really, unfortunately, very impactful, but also I think raises the bar of what we can, as physicians, can do to help our patients get the care they need. And so will end there close to time, but just if anybody has any final thoughts, these are some of the questions that we had as a clinical team, and if anybody has anything to add as we move forward, we'd love other thoughts. So thank you.
So the case is like a consanguineous marriage, right? There is so much homogeneity and
yes, that is the thinking there.
So when you guys do, I don't know, I'm not. I always curious. Do you tell them not to have kids or something? It just that's not related. But I'm thinking I think the only cure is bone marrow transplant, right? There's nothing else you can do.
Well, I think these are really good questions for discussion. So I would say that is not I do not make that recommendation about having children. I think it's just talking about the risk in a way that is health literacy. I think we have to build a lot of health literacy. I would say in terms of treatment, so I think prophylaxis, certainly I think there's things that we can do. I think, looking at the titers, I think we don't specifically have, I think, evidence in this. Thanks, Zach, for joining us in this disorder, but sort of extrapolating lessons from, say, hyper IG, autosomal dominant STAT3. We regularly offer Bactrim prophylaxis, and I think that really, and things like bleach baths or other topical decolonization approaches can be very effective for reducing the burden of staph skin infections. I think immunoglobulin replacement, I think, is really a good tool. I mean, the titers were really poor, and I think potentially getting her on a regular replacement may help with that. So I think we have some tools in terms of prophylaxis, and I don't know if Mira. I know Kristen Ebens is typically has been our other nicer co-PI, and I talked with her about that a little bit. I don't know if either Kristen or Mira is on and wants to say anything about how you might approach this from a transplant standpoint.
Beth, I am just dipping my toes in IEI transplants, and I probably would defer to Kristen.
Yeah. I think, the short answer is I think it's, worth, we need to consider the natural history. And I think these are still really, really uncommon cases. So we don't totally know, but I think there's some indication that there's these patterns of potentially life-threatening transplants. And I think it's often harder to find, the donor situation is more challenging in some of our patients that are not well represented in the donor databases. And so we just had, this has been an issue for some of our patients, is finding good donors, and I think that it impacts the discussion. But I guess our initial thought is if we could get this patient into care, we would certainly want to start having the discussion about the risks and benefits of transplant. And we're struggling with some real issues of getting them regularly in for visits. And I think it means that's sort of just getting into care regularly and starting prophylaxis is a place we really are trying to start from and make headway on before we probably think about embarking on transplant, which I think would have a lot more requirements in terms of, complications and things. So I don't know if you have, in that context, Mary, I don't know if you have anything else to add.
Yeah, I think, like Beth, as you know, I think there's things we can do versus things we should do. And, again, it's a discussion of the family's goals, and also just being aware that, transplant is not magic, and there's, a risk of death. And so sometimes you exchange one chronic disease for another. So yeah, I don't think I could put it any more eloquently than you did, Beth.
There is a question, are you planning on a functional assay for this variant, and where? I am open to suggestions if anybody knows of anyone who is more actively working on this. We do, with Dr. Billington and our geneticist and I share a lab space, and we're sort of trained as cell biologists, sort of immunologists, sort of lab folks a little bit. And so it may be something we will sort of tackle some of these, but if there's other folks around who are working on this, I'd be very happy to collaborate. So
well, I may miss the first part. Have you tested parent?
We did a duo sequencing, so I'm not sure what the discussion was. I think that the father was not available, was not in the analysis, but we have mom.
Okay, but I know in Cincinnati, when Jack was there, he ran a lot of ALPS assays, including the apoptosis. I saw Ashish there. Maybe they're still offering this test. He definitely do double negative T cells, but it seems like it's negative, right? You don't see
Yeah,
like
normal double negative T cell populations, yes. And I think this is the same assay that this apoptosis assay. So yes, I believe. Let me see if it's
yeah. Well, while you're
yeah,
looking, I will
that's
just
both.
quickly look at this variant. Actually, in African population, they have 74,000, and there's no homozygous.
Okay.
Actually, really support this is
Yeah.
properly pathogenic, and there's no homozygous across all populations. And the amino acid pretty conserved. I would say definitely the older mammal. Yeah. And what else? Oh, if you look at the splice AI, like at least sift, polyphen, primate AI, all support pathogenic cat also. So I would say please put this case in the public domain. Either so we can fund it.
Yeah.
Yeah, this is important because if you not funding it, it's rare. It's very rare. When I was in Cincinnati, at least we don't fund a lot of CASPAS A or CASPAS 10.
Yeah.
You get a lot.
So yes,
Yeah.
Ashish Kumar is saying, please deposit in Clinvar. Yes.
Yes. Please do
You're
that.
getting beyond my humble ID skills, but I will work with our molecular diagnostic lab and confirm with our geneticist that we're doing all the right steps to get this out there.
Yeah, at least the parents willing to, the other parent can test, either. And then if you do random function, probably use them as a control as well. So that would be very helpful.
And I think, yeah, so I think Ryan Nelson had this apoptosis assay on his radar. I think the challenge has been getting the child in. And so I think it's helpful to have some of our children's folks. So wherever in the city when we get to see them again, then I hope we can kind of help advance the overall plan of care and get some of these studies sent. Yeah. And so there's a comment, protein biomarkers would be interesting to see the patient's inflammatory state. Do you have anything you want to say anything more for teaching purposes about what you're specifically looking for and how you would be thinking about that?
Sorry, I'm from CCHMC, the assistant director for the diagnostic immunology lab. It's just a process for some of our patients who undergo cyst testing, that those are the things that they usually order. Although this is CAS-Base 8, for ALPS patient, IL-10, IL-18, serum fast ligand are some of the ones that are usually ordered.
Okay.
So.
Right. Any other, and I'll just acknowledge, so our learning objectives were sent out. I hope we feel that we've accomplished those. And I just wanted to acknowledge the team of folks that helped me put this present and contributed data for this patient. And really it's a multi-specialty team that we have here in the Twin Cities. And I think it's getting all those perspectives that really helps us do all the things for our patients. So